Hello and good morning. So we start today's session, and it's on goiter. Hello, let's see the sound system. It's on a goiter and nodular thyroid disease. So what's a goiter? Goiter is an enlargement of the thyroid gland, a swelling in the front of the neck, which moves on swallowing, and it may occur in both hypothyroidism and hyperthyroidism. And a nodule is a lump or localized growth of cell in the thyroid gland. They can be benign or malignant. Now, what are the complications of the goiter? Let me check the things. So, the complications of the goiter are calcification, C, D, E, F, G, H. C for calcification, D for degeneration, only uppercase, and F for fibrosis, G for a growth or a tumor, and H for hemorrhage. So these are the complications of a goiter: calcification, degeneration, fibrosis, growth or a tumor, and hemorrhage. Now goiter classification on a cause. Three causes: biosynthetic defect, which is more common in the Western world and USA and developed world. Number two, iodine deficiency is the most common cause of goiter worldwide, and it may be due to autoimmunity, antibodies. The biosynthetic defects and the iodine deficiency have common in them that they have decreased thyroxine, decreased TSH, increased TSH, and increased radioiodine uptake. So both of them, iodine deficiency goiter and a biosynthetic defect goiter, have increased TSH, increased radioactive iodine uptake, but decreased thyroxine. And in the autoimmune causes, we have TPO antibodies, which are present in the goiters of both Graves' disease, which is hyperthyroidism, and Hashimoto's thyroiditis, which is hypothyroidism. It has TSI antibodies, which are stimulating antibodies, which stimulate TSH receptor, increasing thyroxine production, and TSI inhibitory immunoglobulins. They attach to the same TSH receptor and they decrease the thyroxine production that occur in Hashimoto's thyroiditis. Now, goiter classification on cell type. It may be anaplastic cell, which which occur in cancer, hyperplastic epithelium that occur in Graves' disease and in iodine deficiency. It may have fibrous tissue that occur in Riddle's thyroiditis, lymphocytic infiltration that occur in Hashimoto's thyroiditis, and a foreign body granuloma occur in Dequarian thyroiditis. So this is the goiter classification on cell type. In the anaplastic type, we have cancer. There are four types of cancer. Uh, Papillary thyroid carcinoma, most common, occurs in 80% of cases, and it causes local invasion. The second common is the follicular thyroid carcinoma, which occurs in 15% of cases, but it causes um, distant metastasis. Somoma bodies are characteristic of papillary carcinoma. The other two types are medullary carcinoma of the thyroid and the anaplastic carcinoma of the thyroid. Then we have the second common cause in the classification is the Graves' disease, which has cell scalloping, collapsed collapsed folliculi because of the excessive activity. The colloid is used, so the follicle gets collapsed, and there is patchy lymphocytic infiltration in the Graves' disease, and the cytoplasm of these cells is pink in color, eosinophilic. Then this is we have the fibrous tissues, and this is occurring in Riedl's thyroiditis. Then we have Hashimoto's thyroiditis, we have lymphocytic infiltration. So lymphocytic infiltration in both Hashimoto's, but it's patchy in Graves' disease. And then we have this foreign body granuloma. Now, goiter classification on the basis of the size and nodules, it may be diffuse or nodular. Both of them, diffuse and nodular, both may be toxic and non-toxic. Nodular may be single nodule or multiple nodular goiter. It may also be toxic and non-toxic. Now let's discuss the simple diffuse goiter. In simple diffuse goiter, thyroid is symmetrically enlarged, asymptomatic, non-tender, smooth and soft. This is a simple, and the thyroid function is normal. There are no nodules or no hyperthyroidism. Microscopically, the simple non-diffuse non-toxic goiter, they have uniform follicles. See here, uniform follicles filled with colloid. So the simple diffuse non-toxic goiter, what are the causes? Puberty, pregnancy, iodine deficiency, biosynthetic defects, goitrogens, and drug. These are the causes of simple diffuse non-toxic goiter. As I earlier told, that these two, iodine deficiency and biosynthetic defects, dishormonogenesis, have the feature common: decreased thyroxine synthesis, increased TSH, and increased radioactive iodine uptake. Then, and the iodine deficiency patients, they excrete more than 90% of iodine every day, which is taken in. And let's see, what is the test to check for the 24-hour urinary iodine test? That the 50 milligram iodine load is given, and 90% of this is excreted in the urine in 24 hours. The other gold standard test for urinary iodine assessment is ICP-MS test, inductively coupled plasma mass spectrometry, or alternative. But this test, the gold standard test, is very expensive and is not available in all the centers. Or alternatively, it's a urine iodine to creatinine ratio test. So, and this iodine deficiency causes, why does it cause goiter? It causes due to compensatory effort to trap the iodine. And there is increase in the size of the thyroid gland and increased vascularity. Now, the next cause is goitrogens. So, what are the goitrogens? Goitrogens are the substances that inhibit thyroid hormone synthesis and promote thyroid tissue growth because of the increased TSH stimulation. The two causes of the goitrogen that cause goiter are food, it may be a food or maybe a drug. The which food cause goiters? Vegetables of cassava and brassica family, they have thiocyanate, and the example of this food is cauliflower, cabbage, Brussels, and sprouts. And the milk from goitrogenic regions also contains goitrogens in them, so they may also cause goiter. And a long standing goiter may become nodular. The other cause, drugs that are goitrogens are mnemonics is NPT3, N for nitrates, P for perchlorate, and 3T, thiourea, thiouresyl, and thiocyanates. They are goitrogenic. Now, sign symptoms of the non-toxic goiter, diffuse goiter. It's usually asymptomatic, but may have pressure symptom. So why the pressure symptom develop? Because of the enlargement of the thyroid. It causes presses on the trachea and esophagus, causes its obstruction. So these pressure symptoms are dyspnea, dysphagia, and dysphonia. Why dysphonia? Because The recurrent laryngeal nerve that supplies the vocal cord passes behind the thyroid gland. An enlarged thyroid presses on the recurrent laryngeal nerve, causing dysphonia. And dyspnea is due to the compression on the trachea. And dyspnea, when does it occur? It occurs when more than 70% of the trachea is obstructed. And what tests demonstrate esophageal obstruction, which causes dysphagia? It's a barium swallow through that is seen here, which obstructing the esophagus. Now, what's Plumberton sign? It's occur in large retroesternal goiter, which causes venous distension, fainting, and dyspnea especially when the arms are raised above. Now, thyroid function is normal, TSH normal, but T4 may be decreased and T3 is normal. So, why T4 is decreased? Because T4 is converted to T3. T3 is the active physiological form. So, T4 may be a little bit reduced. And if the cause is autonomous thyroid, that there is decreased TSH and TPO antibody increased risk of autoimmune thyroid disease. Now, the treatment of simple non toxic diffuse goiter. The treatment depends on the size and the cause of the goiter, whatever the cause we have just discussed. And if goiter is due to iodine deficiency, so what's the treatment? Then treatment is not thyroxine, it's a Lugol's iodine or potassium iodide. Radioactive iodine treatment shrinks the gland if it's given. So if thyroid is producing too much thyroid hormone due to autonomy, it's a radioactive iodine that shrinks it. Thyroid hormones are given for underactive thyroid gland. So these are the causes and the treatment and different clinical features of the thyroid gland, where the simple diffuse non-toxic goiter, puberty, pregnancy, iodine deficiency, biosynthetic defect, goitrogens and drugs, and then we have the urinary testing of the iodine, then goitrogens, food or drugs, vegetables of cassava and brassica family, and the drugs are nitrates, perchlorate, and thiourea, thiouresil, and thiocyanate. And the pressure symptoms are dyspnea, dysphagia, and dysphonia. And then we did the treatment part, and now we go to the non-toxic nodular goiter. So this was non-toxic diffuse goiter. Now we go to non-toxic nodular goiter. It may be a solitary nodules, multiple nodules, both. Let's discuss the solitary cold nodule, which occur in 95% of cases. The most common cause of a nodule is a solitary cold nodule non-functioning. It's palpable and palpable if it's more than 1 centimeter in diameter. And it occurs in 95% cases, but is palpable only in 5% of cases. But ultrasound detects more. It detects 25% of the thyroid nodules, cold nodules, and as small as zero point 0.3 millimeter or 3 millimeters. These cold nodules have low radioiodine uptake. This is important feature from them. And the size palpation 1 centimeter palpable on ultrasound is detectable at 3 millimeter in size. They are non-functioning. So what's a nodule size? A nodule of less than 1 centimeter is benign. And most patients have distorted thyroid nodules, have fibrosis in them. So in the nodule size, 1 centimeter, less than 1 centimeter is usually benign. 1 to 2 centimeter has increased risk of cancer, and more than 2 centimeter has more risk of cancer. So when a ultrasound biopsy is performed in a nodule, if it's in 1 centimeter diameter and with microcalcification. So we'll come to the microcalcification which is seen on ultrasound and is a feature of malignancy. Number two, if it's more than 1.5 centimeter and have solid or coarse calcification. Number three, if it's 2 centimeter in diameter or larger and has mixed solid and cystic components. So one less than 1 centimeter is benign. 1 to 2 and more than 2 is a risk of cancer. And the ultrasound biopsy is performed is if it's 1 centimeter with microcalcification or more than 1.5 centimeter with solid or coarse calcification and 2 centimeter in diameter which has mixed solid and cystic component. And if a nodule is more than 4 centimeter, then it should be removed. So what percentage of the cold nodule become malignant? 10% may become malignant. Even 5% of hot nodules, which we'll discuss later now, they may also become malignant. So 10% of the cold nodule, 90% are benign. And radioactive, let's discuss the radioactive iodine in cold nodule. They don't take the cold nodule, they don't take the cold nodule, the radioactive iodine. So this is a cold nodule here. This doesn't take the radioactive iodine. This one also in this here, which is a multinodular goiter, this one is cold nodule taking less. The hot nodule takes more radioactive iodine, excessive. This is grave disease, takes uniformly increased radioactive iodine. And this is thyroiditis, which doesn't take the radioactive iodine. Also malignancy. See here, this one, it doesn't take the radioactive iodine. So the radioactive iodine uptake is low in cold nodule here and in the thyroiditis, in malignancy. It also takes low radioactive iodine in thyroiditis, acute phase of the thyroiditis. Yeah, where is that? It will come. I'll explain it when it comes. And then these hot nodules, they take more, and the grave disease takes more. So this is the cold nodule taking less. Cancer also takes less radioactive iodine. Now the cold nodule may be a benign or a neoplastic in 10% of the cases, and there develops follicular thyroid carcinoma in the cold nodule in 10% of cases, and this follicular thyroid carcinoma occur in 10 to 15% of thyroid cases, but it has more distant metastasis to the bones and the lungs. Now the benign nodule. So the cold nodule, two parts, benign and malignant, and now benign may be filled with a colloid, may be inflammatory nodule, may be cystic. In one-third of cases occur cystic nodule, or it may be a follicular adenoma. See, follicular adenoma is in benign nodule. It's not included in follicular thyroid carcinoma malignancy. It has these sheets. Now, one-third of benign cystic nodule, most common, one-third cases occur, and it's thyroid cyst, and is diagnosed by the ultrasound, and it appears jet black on ultrasound. I'll show you in a moment. And hemorrhage in a cyst may cause pain, or it may cause localized swelling. Hemorrhage, a pain and hoarseness in a cyst may be due to malignancy also. So, what about the clinical features of a benign cyst? Most benign nodules are asymptomatic, slow growing, non toxic, need simple follow up without treatment. So, the benign nodules are non toxic, asymptomatic. They are slow growing. Fast growing may be malignant or a suspicious nodule, and they need simple follow up without any treatment. Investigation in a solitary or suspicious cold nodule is that TSH is normal, and FNA, fine needle aspiration biopsy, shows more than 70% are benign, and they are monitored by ultrasound. 20% are non-diagnostic, and 10% are malignant. As I already explained, follicular thyroid carcinoma that occur in 10 to 15% of thyroid cancers. So, what's the ratio between the benign neoplasm and a thyroid carcinoma, benign nodule? And that's 10 is to 1. 90%, as I told, are benign and 10% are malignant. So, the ratio is 10 to 1 between benign and malignant. And male female ratio is 1 to 4. More in female, 4 times more in females, these nodules. And what's the similarity between the cold nodule and a malignant nodule? That both of them take less radioactive iodine than the normal thyroid tissue. So, what are the indications for fine needle aspiration cytology or biopsy? Nodules of more than 1 centimeter with two ultrasound criteria of malignancy. In other video, we discussed the ultrasound features. They are microcalcification, hypoechogenicity, irregular border, increased vascularity are the features of ultrasound with malignant nodule. They may have extracapsular lymph node invasion and have a history of head and neck radiation. So these are the indication for FNA biopsy. Nodule of more than 1 centimeter with microcalcification or hypoechogenicity, extracellular or lymph node invasion, and a head and neck radiation history of that. Now, features of the follicular thyroid carcinoma that it has, which occur in cold nodule in 10% of cases, has trabecular or solid pattern of follicles, local invasion to the thyroid parenchyma capsule in blood vessels. It spreads more, follicular thyroid carcinoma spreads more to distant organs, lungs and bones. And the treatment is of the follicular carcinoma is surgery followed by radiation or systemic therapy depending on the cancer stage. We'll come to the cancer stages when we discuss cancers. Cytopathology is non-diagnostic in 20% of cases. So what's the difference between benign and malignant nodule on examination? So examination differences in benign and malignant nodules are that consistency, soft in benign nodule and hard in malignant nodule. Size, small in benign nodule. Benign nodules are smaller and malignant nodules are larger. Mobility. Benign nodules are mobile and malignant nodules are fixed. Growth is slow in benign nodules and fast in malignant nodules. Borders are circumscribed in benign nodules and ill-defined and irregular borders in a malignant nodule. Lymphadenopathy absent in benign nodules and present in malignant one. Sorry, got dry throat. And then local invasion absent in the benign nodule and present in malignant nodules. Now, if there is insufficient evidence with rapid alignment, then ultrasound guided FNA biopsy is done. If it's benign, then second biopsy in 2 to 5 years to confirm the benign status of the nodule. Diagnosis by ultrasound, CT, MRI. Then ultrasound advantages. Number one, ultrasound detects a non-palpable nodule, which is not palpable on examination. So it can find up to 3 millimeter inside. Ultrasound accurately localizes the nodules and selects the correct nodule if there are multiple nodules to take the sample accurately. Ultrasound differentiates between a solid and a cystic lesion and identifies adjacent lymphadenopathy and diagnoses suspicious nodules with microcalcification. So, what are the ultrasound biopsy indications on a nodule? So, I already explained it. Let us revise it. 1 centimeter with microcalcification, more than 1.5 centimeter with solid or cold calcification, 2 centimeter or larger with mixed solid and cystic components, and 4 centimeter larger may be removed. Now, what are the ultrasound characters of a benign nodule? Filled with colloid, not with blood. No blood in a nodule, in a benign nodule, because if blood is present and it's malignant. So it's filled with colloid and edges are sharp and circumscribed and regular. Whereas ultrasound suggestive of malignancy are microcalcification, hypoechogenicity, irregular border, and increased vascularity in blood. So these are the features of benign and malignant nodules, ultrasound features, and advantages of doing a ultrasound on a nodule, and a difference, examination difference between benign and malignant nodules. We discussed all of them. Then we go to the treatment. Majority are benign, so need no treatment, or otherwise levothyroxine or potassium iodide for benign solitary cold nodules. L-thyroxine suppression therapy for 6 to 12 months to determine if nodule decreases in size. And what the radioactive iodine does, it shrinks the nodule. Thyroxine treatment doesn't shrink the goiter, but radioactive iodine shrinks 50% size, half. And surgery for suspicious malignant nodule. And follicular adenoma or follicular thyroid cancer. Total thyroidectomy followed by radiotherapy with radioactive iodine. Right? Thyroidectomy followed by radiotherapy with radioactive iodine for the solitary malignant thyroid nodule. The malignant cold nodules may be a carcinoma, a lymphoma, or a metastatic. The most common type of carcinoma I already told earlier, it's papillary carcinoma of the thyroid, occurs in 80% of cases, but is slow growing and it has local invasions. Lymphoma that occur in cold nodules are B cell non-Hodgkin lymphoma. And the Hodgkin lymphoma has a Reed Sternberg cell, owl-eyed appearance cells like this. They are pathognomonic of that Hodgkin's lymphoma. Now, these are the features in ultrasound, hypoechogenicity that appear on malignant nodule, and microcalcification and irregular border. So these are the hypoechogenicity, microcalcification, and irregular borders. And this is cyst, which is jet black in color, cystic appearance. Now, the next topic is non-toxic non-toxic multinodular goiter, non-toxic multinucleated goiter. So what's a nodule? Nodule is a palpable swelling or lump of more than 1 centimeter in thyroid gland on examination, whereas ultrasound detects more thyroid nodules, smaller ones, 25%, which are as small as 3 millimeter. Non-toxic multinodal goiters occur in 12% of the adults, more in women, more in elderly, and more in iodine deficient areas. Multinodular goiter, non-toxic. On examination, the architecture is distorted because they are multiple, and the growth increase in size that causes distortion in architecture. Because of the multiple nodules of varying size, they cause trickle deviation, which is common, and so they cause pressure symptoms. Multinodular goiter patients have pressure symptoms. They may be asymptomatic, but the goiter, this is the gross pathology of the multinodular goiter. Hemorrhages, fibrosis occur, scarring, and irregularly filled follicles. Fibrosis is often extensive. The features are of these multinodular goiter are the same one, same mnemonic almost: CDEFGH, GRS, calcification, degeneration, fibrosis, growth, hemorrhage, right? These are the call, the extension. There occur hyperplasia and involution in these nodules with an irregular enlargement. See, they are irregularly enlarged. Morphologically, they are hypercellular regions filled with colloid. Hypercellular region filled with colloid. Scan or MRI. It evaluates the anatomy of the goiter and extent of the substernal extension. These are the multinodular goiter. So why do they occur? Most nodules are polyclonal in origin and they cause hyperplasia and hyperplastic because of the locally produced growth factors and cytokine. It may also be due to monoclonal lesions. Monoclonal lesions are due to mutation in the genes. Polyclonal lesions are due to growth factors and cytokines produced that cause hyperplasia and hyperplasticity. And then we have and this occur mutation monoclonal that causes increase in adenylyl cyclase and cyclic AMP that lead to increased thyroid cell activity and function. And a long standing iodine deficiency endemic goiter may also be converted to multinodular goiter. And iodine deficiency is the most common cause of endemic non toxic goiter worldwide. Whereas in the Western world, it's the biosynthetic defect. That's the most common cause. Give me a break and let me see. Uh, yes, let me go back. Okay, let's see. Okay, where's my. Okay, now the clinical features of the multinodular goiter may be asymptomatic when it's small, but compression symptom. Dyspnea, dysphagia, dysphonia, right? Due to compression of trachea, esophagus, and obstruction to the recurrent laryngeal nerve that causes dysphonia, that supplies the vocal cord. And trichomalacia causes inspiratory steroid. I already told that dyspnea occurs when more than 70% of trachea is obstructed. And what test demonstrates esophageal obstruction is the barium swallow causes dysphagia. Sudden pain is usually due to hemorrhage or malignancy, and sudden pain and hoarseness may also be due to malignancy because hoarseness is due to the involvement of the recurrent laryngeal nerve that passes behind the thyroid gland to the vocal cords. So in multinodular goiter, non-toxic, yeah, thyroid function is usually normal. The risk of malignancy is same as that of occur in solid nodule. So the risk of malignancy in solid cold nodule, solitary cold nodule, or malignant and multiple nodule is same. It's about 5 to 10%. And what are the sonographic characters that suggest malignancy? I already explained: microcalcification, hypoaquagenicity, and increased vascularity. Now, treatment of the non-toxic multinodular goiter. Three treatment: thyroxine, radioactive iodine, and surgery, thyroidectomy. L-thyroxine is useful in the young people and halts the thyroid stimulation. Disadvantage of thyroxine is that it rarely decreases the thyroid size. It doesn't decrease the thyroid size. But which treatment decreases the thyroid size? It's radioactive iodine. that decreases the goiter size by 50%. And second disadvantage that it may induce thyrotoxicosis, right? The calcium containing substances should not be used about 4 hours before or after taking the thyroxine substances. And the example of them calcium containing substances are antacids, milk, cheese, and yogurt. Now, if the multinodal goiter has autoimmunity as a cause, then iodine containing substances increase the thyroxine production, and a radioactive iodine, I already explained, that decreases the goiter size by 50%. Radio ablation, and then you can do a radio ablation, and then electrical current and heat shrinks the nodule. So after radio ablation, electrical current and heat may also shrink the nodule. Surgery is effective, but it has risk. What are the risks with surgery? It may cause infection, it may cause bleeding, it may cause hypoparathyroidism, and it may cause tetany, decreased calcium. Normal calcium is 10 milligram per 100 ml, and it's the parathyroid hormone produced by parathyroid hormone, which is parathyroid hormone. Is four parathyroids are attached to the posterior surface of the thyroid gland. So if it's removed, they may also be removed, right? So it causes this, and it might cause hoarseness or defects in the voice because of damage to the recurrent laryngeal nerve that passes behind the thyroid. Now, the toxic goiter. Again, toxic goiter may be diffuse, multinodular, or may be a single solitary toxic adenoma. Example of diffuse toxic goiter is Graves' disease. Let's discuss the hyperfunctioning solitary nodule. This one is a hot nodule. We already discussed the solitary cold nodule. Now we discuss the solitary hot nodule or toxic adenoma. The features of that are that this one takes more radioactive iodine. The cold nodule doesn't take decreased radioactive iodine, but solitary cold nodule takes more radioactive iodine, and it is increased T3 T4 with decreased TSH. This is the thyroid function in hyperfunctioning toxic adenoma. And another feature is that rest of the thyroid gland, thyroid tissue is hypoactive. It doesn't take, see here, this is the hot nodule that takes more radioactive iodine. The radioactive iodine concentrates more in the hyperactive area or hyperactive nodule. But the remaining of the thyroid tissue is hypoactive, take less radioactive iodine. So this is here cold nodule taking less radioactive than, but this one is hot nodule here. If you see this, it takes more radioactive iodine. This one has multiple cold and hot nodule both. Cold takes less. This is multinodule, but hot takes more. And this one is Graves' disease, take uniformly increased radioactive iodine, whereas thyroiditis doesn't. So what's the cause of hot nodule? Most patients, most patients have mutation in TSH receptor, a dominant type of receptor that increases the activity of the tissues or cells in the thumb in this nodule, and this occur in more than 90% of cases. So what it causes? The mutation, the dominant mutation causes increased adenylate cyclase activity and cyclic AMP that increases the thyroid cell function. So this is the etiology of the hot nodule mutation, a dominant mutation in the TSH receptor. Thyrotoxicosis in hot nodule, solitary hot nodule, is mild without features of Graves' disease. And histology shows follicular cells are hypertrophic and hyperplastic with little colloid in them. Because of the hyperactivity, colloid is used. So colloid gets smaller, and there is marked dilatation of the follicle with flat epithelium. Definite diagnosis with thyroid scan. So hot nodule, definite diagnosis, demonstrates hot area and suppression of extranodular thyroid tissue. Here, a hot nodule has increased radioactive iodine uptake and remaining of the gland takes less. Then we have so the radioactive iodine intake is increased and decreased in remaining, and the thyroid function is decreased. Radioactive iodine uptake makes the diagnosis so FNA biopsy is unnecessary in a hot nodule because the chances of malignancy are very little, less than 5% in a hot nodule, whereas chances of malignancy in a cold nodule are more, they are about 10%, right? And the ratio of benign and malignant nodule is 10 is to 1. Now, when should a biopsy be performed in hot nodule? When the nodule is more than 1 centimeter plus with microcalcification, or it's more than 1.5 centimeter with solid or coarse calcification, or it is 2 centimeter or larger, that has mixed solid and cystic components or blood, right? So these are the indications for a biopsy, ultrasound biopsy. Okay, then we have a treatment of the toxic nodule. Three treatments: drugs, radioablation, and surgery. Radioablation is the treatment of choice for hot nodule. Why? Because the radioactive iodine, it concentrates in the hyperactive one, not in the normal thyroid tissue. So the drugs, antithyroid drugs and ethanol, antithyroid drug propyluracil and methimazole, and ethanol injection, repeated ethanol injection repeated ethanol injection in under ultrasound guidance ablate the hyper-functioning hot nodule. So I'm sorry, some disturbances there going on. Let's see. Hang on. Let me see where is it. Okay, I'm back. There was some disturbances. I'm sorry for that. Let's go back to the file. Oh, shoot. Let's go back to the file. This is a StreamYard. Okay, now are we back? Let's see. Is it? Yes. Oh, shit. Yeah, almost here. Okay, then we have this treatment of a toxic nodules, hot nodule, drugs we were discussing, antithyroid drugs, ethanol, repeated ethanol injection ablates the goiter, hyperfunctioning nodule, and then we have a radio ablation treatment of choice, and iodine 131 is concentrated in the hyperfunctioning nodule but doesn't damage the normal tissue. Disadvantages of radioactive iodine treatment. It may cause hypothyroidism in 10% of cases in 10 years, 5 to 10 years. Hypothyroidism with because the iodine it may cause hypothyroidism. It may also cause hyperthyroidism. If you see Wood-Chekhov effect, increased trapping and decreased trapping. And then we have surgery. Surgery, adenoma enucleation or lobectomy is the treatment of choice for the surgery, adenoma enucleation or lobectomy. And before the surgery, beta blockers are given. Then we come to the toxic multinodular goiter. They have autonomous hyperfunctioning nodules. They cause thyrotoxicosis. These toxic multinodular goiter are the second most common cause of thyrotoxicosis, excessive thyroid production. The most common cause of thyrotoxicosis is Graves' disease that occur in about 60 to 80% of cases. This is multinodular, toxic multinodular goiter, right? Seen on radioactive ultrasound, radioactive iodine, which takes more, concentrated more in the hyperactive nodule. The non toxic multinodular goiter may be converted to toxic multinodular goiter. And but this one occur in more in elderly. The toxic multinodular goiter, they occur more in elderly, and it's a disease of older adults with cardiac symptoms, tachycardia, dysrhythmia, or atrial fibrillation. And they have tremors, weight loss, myopathy, bone loss, tracheal compression. But these toxic multinodular goiter do not cause ophthalmopathy or dermopathy, but they cause other features weight loss, tremors, fibrillation, tachycardia. This is a disease of elderly and a second most common cause of thyrotoxicosis, toxic multinodular goiter. Its pathogenesis is similar to that of non-toxic multinodular goiters, except for functional autonomy that they have. Otherwise, they are polyclonal in origin due to polyclonal in origin, and there is and the hyperactivity and hyperplasticity is due to the locally produced growth factors and the cytokines. And it may also be due to monoclonal lesions where there is mutation in the genes that causes upregulation or increased activity of the cyclic AMP and adenylate cyclase. Now, thyroid function in toxic multinodular goiter decrease TSH because they produce increase T3, T4. T4 in normal to increase, T3 increase because T3 is physiologically active and T4 is converted or deiodinated to T3, the physiologically active form of thyroxine. How about radioactive iodine in toxic multinodular goiter? Because it causes distortion. So there is heterogeneous radioactive iodine uptake with multiple areas of increase and decrease radioactive iodine uptake. Distortion in anatomy and physiology that causes heterogeneous radioactive iodine uptake in toxic multinodular goiter. Now, the treatment of toxic multinodular goiter, antithyroid drug, radioactive iodine, and surgery. Antithyroid drugs are given with B and the beta blockers also. And radioactive iodine is used for areas of autonomy and that decreases the mass of the goiter. Surgery is a definite treatment. If there are pressure symptoms of breathing, dysphagia, dysphonia, and dyspnea, then it's a surgery is the treatment of choice. And surgery is done for partial thyroidectomy or complete thyroidectomy with anti-thyroid drug given before the surgery. We will discuss this anti-thyroid drugs uh, when we discuss the Graves' disease, how are they used. And then we have thyrotoxicosis and hyperthyroidism and Graves' disease. So for today, I think this should be the end, and we'll discuss the Graves' disease and thyrotoxicosis in the next session. So for now, I think it should be done.